Thank you for coming to this jointly sponsored event between the Fielding School of Public Health and the School of Medicine. I'm Inez Ponce. I'm the director of the Center for Global and Immigrant Health at the Fielding School of Public Health, and I welcome you on behalf of our Dean, Jeremy Hyman. I also would like to acknowledge Dr. Tom Coates, who is in the front seat for helping organizing this event. So I just met Keith Martin in a flash really quickly in Washington, D.C. One thing that I can say that connects me with Keith, because I really don't know you at all, is that I believe you're an immigrant, and you came from London, or you came from the UK to Canada at maybe as a young age, like myself, and then studied in Toronto. He's an MD. He also is a former parliamentarian from Canada, so which will suit us well because since our AV doesn't work, he has exceptional oratory skills, so he's going to have to take care of that. So apologies for that. And from your bio, that you were a clinician for many years. You practiced emergency medicine and general practice in Canada, but also served as a physician in a rural region in South Africa during the Mozambique War. So an incredibly fascinating individual. Again, I only met you once. Look forward to your talk today and look forward to future collaborations. I do want to say that a plug-in for the conference. It was my first time to go to this conference. It was absolutely stimulating, inspiring. The socials were really fun. The people were so engaged and very provocative. And so all that we want in a good conference. So to help us welcome Dr. Martin.
Well, thank you very much, Inez. And this is being filmed, folks, so I hope we can get that clip and put it on our website, because you said it better than just about any of us could. And I don't know about exceptional oratory skills. I define that as being the avoidance of foot-and-mouth disease. And for those of you who watch any kind of parliamentary proceedings, you know it's endemic. So I will suffer from that, and I will tell you that in advance. But it's great to be here, and I really want to thank you very much for inviting me here as Executive Director for the Consortium of Universities for Global Health. When Tom and Inez asked me to come, I said, UCLA, Southern California. It's absolutely stunning, and it's a real privilege to be here. You certainly live in an extraordinary place. What I thought we would do, and we're joined here too by one of your own, Dr. Tim Brewer, who is your Vice Provost and is also the chair of our board. So I said to Tim beforehand that if there are any really tough questions, he will be able to answer all of them. So all of your questions will be answered in an eloquent way today, if not by myself, but certainly by Dr. Brewer. Tom, when he approached me about speaking, he said, how can we make this talk a little bit about global health and an awful lot about your interests in terms of the students and also faculty? And I think that gets to the heart of actually how CUGH was born. So I'll give you just the Reader's Digest version of where CUGH came from. It was started in 2008 when 24 academic leaders saw this incredible upswell of interest on the part of students and faculty in global health. And they thought, how can we actually tap into that, and how can we work better together? Because we weren't. And in particular, how can we actually tap into those who are in disciplines that are not medical, so we can deal with the wide range of disciplines that all of us here know, right, are needed to address the challenges that we see. And so we'll talk a little bit about that today. And CUGH started off with 24 members. In 2011, it had a marriage with a group called GHEC, which was the Global Health Education Consortium. And that group was primarily medical, primarily involved in medical education. They came together. And then the board at that time decided to move the secretariat, which was based at the University of California, San Francisco, to Washington. And I was hired 2 years ago this month to be able to stand up the office work with our board and our members to be able to advance global health. And CUGH's mandate is to work across research, education, and service to be able to reduce health disparities and develop cross partnerships between institutions in high, middle, and low-income countries. And I have to say, things are going very, very well. We've actually expanded quite significantly in a broad range of areas. We also were tasked to be able to strengthen global health programs. And that's why the members came together. How can we create an institution that was going to serve our members here and be able to strengthen global health programs? So that was the other big area that it was involved with. So fast track forward now. Last year, CUGH had 53 members. Now we have 94 paid members. The board has actually expanded who we are. And while we were primarily North American, what's happened, I can tell you quite excitingly, is that we're expanding our engagement with overseas institutions. And for the first time on our board, we have an individual not from North America. And that is Dr. Nelson Siwankambo, who is the principal at Makerere University in Uganda. So this is a great movement, I think, for us to be able to expand who we are and where we are. The other big change is we had a board election this year, and we've had a greater number of women involved. Also, our geographic distribution, as I mentioned, has changed, and also the disciplines have changed. So whereas before we were primarily medical, now we have, and this might sound a little bit like Noah's Ark, but we have 2 nurses, 2 vets, 1 engineer, medicine obviously, law, are all represented on our board. And that's pretty exciting to be able to expand all those disciplines and how we bring those in. So what I thought we would do today is, are the slides working at all, or we're out? Okay, thanks, Kathy. So we're going to, all these incredible photographs we have are not going to be shown. So now you have to pay attention to me. It's going to be grim, so try to stay awake. So as we look forward into the future, I think all of us are paying attention to the crisis in the Ebola outbreak in West Africa. Who here has been to West Africa by any chance? Anybody into either Sierra Leone, Liberia, or Guinea? Right. So when you fly into those areas, you are not, I hope, you're struck by one, I'm struck by one thing that's dramatic, and that is the utter lack of infrastructure, or near total lack of infrastructure. So before this Ebola outbreak actually took place, you're dealing with countries that actually had a almost non-existent infrastructure to respond to their own needs, let alone have something catastrophic like Ebola present itself. So what we're seeing now, of course, is an acute situation based on an environment where there's very little infrastructure. Herein lies an incredible opportunity, right? How can we work and collaborate effectively with countries like Guinea, Sierra Leone, and Liberia, where the greatest needs of the world exist, to be able to meet their own broadly defined global health needs? Is there a role for North American institutions in being able to address that? We think that there is. And in building capacity and sharing knowledge and in sharing best and good practices, being able to identify trainers amongst our members and linking them up with institutions in low-income countries, we have a chance to be able to build capacity, retain capacity, and share knowledge. This is an opportunity that we at CUGH are tackling, and we've done that in a couple of interesting ways. Our website was old, and we completely revamped it. If you take a look at it, it's intended for a platform for you to be able to use in many different ways. On that website, we've divided the website off according to a number of global health challenges, from mental health to primary care to the One Health, which is the environment and health nexus, to being able to address addiction medicine, maternal health, disaster management, an array of challenges that we face. They're all on there. That platform is designed for you to use. We need you to use that platform to be able to share good practices, to be able to identify training modules that can be useful, and to be able to post them. At CUGH, we've created a number of committees, including a very robust education committee that Tim was involved in and leading, with another doctor, Dr. Tom Hall, to be able to create an education committee that was able to identify good training modules that we can post. That education committee is going to have a mentorship program that's also going to work to be able to strengthen global health programs here amongst our membership. So it's a very exciting platform, and I'd really encourage you to use it, because the strength of that platform to be able to identify information that's usable and to be able to share it is going to be one of the major benefits that we can actually provide to our members. So and it'll only be as useful, frankly, is the ability for people to input and engage on it. That platform also has a significant student section. So on that student section will be job opportunities, training opportunities, a mechanism for students to be able to collaborate and work together and engage together on dealing with the challenges that they face. So please use it and please share it. As we look at the global health challenges before us, we spoke earlier about the lack of infrastructure. We can see that there are major challenges that are taking place, from the rise of NCDs to the persistent problem of infectious diseases, to the lack of capacity, to new changes such as climate change and a lack of sustainability, to the ongoing challenges of corruption and conflict, and the great implementation deficit that exists. Going to any conference, do you not get a little frustrated by seeing the incredible and wonderful array of research that's produced, and then ask yourself, where does that research go? Where does that research go? We were at the APHA meeting a year ago. Was anybody at the APHA meeting? It was a wonderful meeting. If you look at the program, it was about an inch and a half thick. So I did a quick scan of the posters and presentations. I calculated over 9,000 different presentations that were there, posters. 9,000. An incredible research, from dealing with pressing challenges on how to prevent NCDs, to deal with NCDs, to infectious diseases, to you name it, it was there. But what happens to that research? What happens to that incredible collection of knowledge that's produced? There's an implementation gap, right? We can overcome that implementation gap. As a researcher, doesn't it yearn to be able to take the research that you've developed and find a way to be able to scale it up? That's an enormous challenge that we face today. And our website will hopefully enable that to happen, bridging that knowledge needs gap, bridging the implementation gap, not only by providing access to knowledge, but also identifying the individuals who can do the training, and also identifying the institutions that have asked what they need. Not what we're going to tell them, but what do you need, and how can we help you? These are the things that our platform will enable us to do, and we're seeking out to identify institutions that have needs and would like to collaborate with us. If we look into the future, and we were at a meeting at the Public Health Institute, who do some really incredible work, and we were looking at megatrends in global health. And if we look into the future, there's some discrepancies that I think we need to admit and then pivot in how we deal with them. One is that as we move forward, low to middle income countries that have previously relied on overseas help, they're going to take on those jobs themselves, right? Rightly so. So there's going to be a decline in certain jobs overseas for those that are interested in global health. There's going to be an increasing demand for global health challenges domestically, because we know the challenges here. We've had this discussion before. I know when I started with CUGH, some people felt that global health was that which is external to the borders of the US. Now, as a Canadian, I got to be careful where I tread, right? So thankfully, Secretary Sebelius said the following. She said, the United States is part of the global health enterprise. We must not be excluded from it. So all I would do is just take out her words, flash it around. And so Secretary Sebelius said it really well. The US and the challenges within this country are part of the global health enterprise. And much can be done to be able to share innovations here abroad, and also vice versa. We're all in this together, and we have a chance to do this, and what an incredible opportunity that presents itself. We're also seeing in megatrends the economic rise, of course, of middle-income countries. Tragically, the persistent depth of of extreme poverty, particularly in Africa. 30% of countries in Africa have extreme poverty levels above 50%, and that hasn't changed a lot over the last several years. And the inequality issue. GDP can go up, but what actually happens within a country? Who's been to Nigeria? Right. You go from the airport in Lagos into downtown, and it's a bleak environment. On paper, if you looked at the GDP within the country, that's the strongest economy in the whole of Africa, right? Look at northeastern Nigeria, where Boko Haram is wreaking havoc. 40% of the children in northeastern Nigeria are malnourished, are stunted because of malnourishment. 40%. But if you looked at the GDP on paper, you might see an entirely different picture. Unless you hear about things like the head of the Bank of Nigeria asked a question. He says, we're missing $14 billion. Billion dollars. Where has it gone? So what happened to him? He was fired from his job. Corruption kills. So the inequality issue is something that has to be dealt with. It's a very difficult and challenging issue. But herein lies an opportunity for many people with non-medical skills to be able to work to be able to address that challenge. Demographic changes we know about. High-income countries, in many high-income countries, we're seeing replacement levels shrink, reproductive rates shrink below replacement levels. We're also seeing different swaths within poor areas where reproduction rates are very high, particularly in the Sahel, where you have a significant difference between food production and the rate of numbers of children that are being born, which are quite high. And you're also seeing the big youth blip in Africa, which is very exciting in many ways, which can be utilized in dynamic ways. And then, of course, the technology revolution, which we know is breaking down barriers in very exciting ways and democratizing the spread of knowledge. So one of the things we did was we tried to, a question that I'm sure all of you are trying to ask, particularly in faculty and the students, is what makes a better global health professional? So at CUGH, one of the things we did with PHI is we actually asked our members this question. About 20 academic leaders in global health responded, and they said this is what, and these were only US, I might add, these are only US academic leaders in global health that were asked the question, what would it take to make a better global health professional? The next step in this, of course, is to ask low-income partners, what do they think makes a better global health partner and professional? 5 characteristics came to the top. The first one is understanding and seeing trends in global health, in the global health landscape. The second was the ability to work with a diverse range of stakeholders. The third was good interpersonal and communication skills, not having foot and mouth disease. The fourth was adaptability to changing policies, economic and social realities. And the fifth was experience in the field. The second question that we asked of global health leaders was, if you look back in time, what would you like to have known when you were in training? What would help you, using your retrospectoscope, what would make you a better global health leader? What would make you a better global health professional? And these are the 5 characteristics that they came up with that were most important. 1, advocacy skills and understanding the political process. 2, this will come as a complete shock to everybody in the room, fundraising and grant writing skills. Third was increased exposure to global health experts during training. The fourth was strong language and cultural competencies. And the fifth one was monitoring and evaluation, data analysis, and project management. And this presupposes that a person's technical skills, of course, are fine. So in CUGH, we listen to that, and we're going to provide, hopefully, some products and opportunities that will help to address those challenges. One is at our conference that Inez mentioned, last year, or this year, we had an advocacy session. And that advocacy session was with Dr. Judith Palfrey, who is a pediatrician, was head of the American Academy of Pediatrics. She wrote an excellent book on advocacy. So she ran a session on advocacy for individuals who attended our conference. The second one is we will have at our conference a Meet the Funders. I know very few people will go to it. but there'll be people, we hope, that'll come from the big foundations at our conference, so you can meet and discuss and learn what are they looking for in terms of fundraising. The third issue is in exposure to global health experts during training. We're setting up a series of webinars, and we hope that that'll be an opportunity for you to have interaction with global health professionals across a broad spectrum of disciplines. The neat thing about CUGH is, as I mentioned, we're going to tap into a really broad range of very exciting and interesting people involved in global health across a full range of disciplines. So people in medicine can go and listen to engineers that are doing interesting work, and in a similar way, we're going to be able to understand what the needs are across disciplines. We're also working with the American Academy, the AAMC, on pre-deployment programs. The AAMC has a program called GLOW. It's for fourth-year medical students going abroad, but we're going to be working with them to be able to showcase on our site different pre-deployment courses and that you can take or learn about if you're going to go and work overseas. So information that you should know about that will be helpful to you. So in conclusion, what I'd like to just say is that CUGH's member support program we're building out now, and we have it up and running. One is our Global Health Program Mentorship Program. So for those that are interested in actually building up their global health programs, we will have an array of senior members from global health programs across the US that can actually help to grow and strengthen nascent global health programs. And that'll all be on our website through the Education Committee. The second benefit will be surveying information about global health programs in the United States. We have 2 interns right now that are putting out a survey, and the purpose is really twofold. One is to really have an understanding of what the global health programs are across the US, who's doing what where, because there really hasn't been an extensive analysis of this. The second thing is really to deal with minority serving institutions. Minority serving institutions have been largely excluded from the global health enterprise. The administration and the White House is very interested in changing that. So by partnering with the Public Health Institute, the 2 interns in the survey we have will look at identifying minority serving institutions, historically black colleges, Hispanic colleges, and tribal colleges to be able to identify what is happening in global health within those areas and what are their needs and obstacles for them to become part of the global health enterprise in this country. That should be finished early next year, and that information will be online. So it'll be available to everybody to understand what the status is of global health programs, and also to look at what the obstacles are, and hopefully we'll work with them to be able to address them. The Knowledge Hub I mentioned before. We also have a very exciting group out of the University of Washington that's created what's called enabling systems. These are for administrators. Those who are administrating global health programs, these individuals who are very experienced are going to be putting out sessions at our conference. We also have had independent sessions in Washington that we're fully subscribed to. And over the course of the year, we'll run one-day conferences on specific issues that are of interest to you. So let us know what your interests are. And enabling systems will be one of those that we've heard are very important for those who are running global health programs. So before I forget, we have, as Inez mentioned, we have our 6th Global Health Conference happening in Boston next year from March 26th to the 28th. We also have a satellite session the day before, and they're free to join. And they're kind of exciting. We have, for example, one is with the National Cancer Institute on global cancer. So we've had a partnership with NIH with them on global cancer. So they run a whole day session on that. We'll also run a session that will be benefit to students and administrators on running your global health programs and what makes a better global health professional. And the third one is still to be announced. So stay tuned on our website and you'll see the list of speakers and events that we will have planned. The speakers roster that we have right now actually is quite impressive, if I may say myself. Jerry Kirsch from Boston University is the chair of the conference. And he's got people like Atul Gawande coming, which will be very exciting if you know his work. and representatives from some very, very large organizations. Paul Farmer is going to be there from Partners in Health. And as time passes, we will roll out more and more of the individuals who we have. Anyway, I would just ask, Tim, do you want to add anything at all?
No, I think
You sure? Cover the... So if I keep talking, of course, you're going to run out of water, and you'll definitely want to leave and get dehydrated. So perhaps what we can do is just spend a little bit of time to do a bit of Q&A, and we can, that might be more interesting. Yes,
so
Tom.
I'll start. Tom Coates, Center for World Health. Did you bring water with you? Because we have none here.
Yeah.
So, from Canada.
Yeah. Oh, yeah, thank you. That sounds like a military operation to take all of our water.
It's interesting that you now have the delegate from Uganda on the board. And of course, there's been discussion that the global health movement is developed, high-income country dominated, originated and dominated. And there was the debate at the last meeting that Richard Horton wrote about in his Lancet commentary. Could you comment on that? And does it have kind of a traditional colonial development assistance feel to it?
Well, I wouldn't use the word colonial. It's such a hot-button term to use. But what I would say is that we have to actually, I think, look within ourselves as to what are the partnerships that we've had and how do they benefit the host country. Because there's a lot of room for improvement, I believe. Research takes place overseas in low-income countries. I was asked the question, so how is this actually directly benefiting the host country or host institution? Oftentimes, they don't benefit a whole lot. But I think there's an opportunity to be able to use the relationships that exist, either in overseas placements or in research, to twin that with being able to use that partnership and relationship to be able to address their needs, particularly in terms of capacity building and sustaining that capacity. And one of the things that we're doing is creating those partnerships between institutions in high-income countries and low-income countries, partially for the specific issue at hand, but hopefully that partnership will last over years, so that the host country, if things are going sideways or they need assistance or they need some ability to sustain their programs, they can always call back on or continue to work with their partner overseas. So I think we really need to look at ways in which our overseas engagements, our overseas placements, the overseas training that we benefit from overseas also benefits the host institution. One thing we may want to consider is if we have an ongoing relationship with students coming from here to overseas, that there also be faculty members working to deal with building up their own capacity in specific areas. And it can be a very small number of people. I'll give you an example. We all know that the colossal challenge that mental health disorders pose worldwide. And nowhere is it more challenging, of course, than low-income countries. Dr. Claire Payne is a very interesting psychiatrist from the University of Toronto. And I would suggest you Google her name and a program that was started in Ethiopia some years ago. She was asked to go to Ethiopia to give a class. And while there, the Ethiopian psychiatrist said, "We're not really able to train our own psychiatrists. We're relying on you. Will you help us to build our own course?" So she said, "Okay." So she brought some of her colleagues in psychiatry in Toronto to Ethiopia, worked with them to build up the course, and then they said, "Well, can you help teach the course?" Okay. So they went and worked with them to teach, to train, to build up their course, to train their trainers, to train the first groups of psychiatrists. So fast track forward, what's happened? They have gone from, I think they start off with 11 psychiatrists in the country to 41 psychiatrists in the country. They've got their own psychiatric training programs. They're leading it. They've created it. And interestingly enough, they've seeded those mental health care services into the rural areas. And they're retaining that capacity, which is very interesting. And they got the Ministry of Health in Ethiopia to be able to buy into that. So it was a very interesting model in terms of how a very small number of people were able to work by listening to what the needs were in Ethiopia to deal with a compelling and tragic, a profoundly tragic situation that exists the world over. I remember I was in West Africa, in a country I will not name, going along. I used to go into the whatever hospitals or clinics were in rural areas. I was walking by and there was a wall and there was a man chained to a wall. I said, "What is that? Why is that man chained to the wall?" They said, "He is very violent. He's an untreated patient who's psychotic, and we don't have any way to treat him. So the only way that we can protect him and his family and people from him is to chain him to a wall." So there was a bedraggled, dirty, emaciated, floridly psychotic man chained to a wall. That happens. Sorry, another question? Yes, please.
Hi, Catherine Atchison, School of Dentistry. Do you envision in your mentoring program that U.S. institutions or other countries would actually team up with an institution in country? Would there be exchange of faculty and students as part of that process?
At this stage, we don't envision students coming from abroad coming here. We do envision faculty and coming from here to there to build up their capacity as they see fit, as they want. It's very expensive, as you know, to have individuals come here. Maybe that's something for the future. It's not something right now. We're really a facilitator for that partnership. But what the partners decide to do is entirely up to them at the end of the day. And I should also say that one of our first interest groups was with John Greenspan in dentistry. And John has been fabulous, and it's now led by Dr. Brittany Seymour, a very dynamic and energetic and outstanding young dentist from Harvard. And she's really doing a great job devoting her time and effort to build up. It's called GOHIG for...
No, it's Gohira.
Sorry?
Gohira.
Go
Gohira is the name of the group.
here.
No, International for Oral Health.
Oh, okay.
It's called Gohira.
Gohira. Okay, I didn't realize that. Here in our, it's called GOHIG, so Brittany does that. And if you're interested, please, if you're supporting her, please do and mobilize the dentists of the country to get behind that great initiative. Thank you. Did you have a question?
Yeah, so my name is Tracy Wells, and I'm with the Global Health Education Programs in the medical school. I'm just wondering the best way for students to get involved with CUGH. What kind of activities are there for them or opportunities for them?
Well, thank you very much for the question. So the question was, sorry, Owen, I didn't repeat back those last two questions. So the question was the opportunities for students to get involved with CUGH. We have something called the TAC, which is a student group. Jessica Everett's a faculty member who is in charge of that. They have about 12 to 15 students that are involved in that. Any students that want to be involved in CUGH should actually connect with the TAC, and you can get involved in that on our website. We also have a dedicated site for students, and that's a chance for students to be able to use that site to mobilize, to link, to share what they are doing. And essentially it's a platform for them to decide what they want to do and how they want to use it, but it's a platform to help engagement. We also will have students more involved in our committees. We have not done that historically, but there's been a significant change. The board has agreed to have students recognizing the vital part that students play in what we do and in the global health enterprise. So we will have a student representative on some of our committees, including the planning committee for our global health conferences. So as we move forward, more and more we want to make sure that we engage students. And any suggestions you have on how we can do a better job of doing that, please let me know.
Francisco Ramos Gomez from the School of Dentistry also, and thank you for your talk. You mentioned briefly this balance, and I really will appreciate your thoughts and your comments about your plan to really get us focused more of the whole notion of think globally but act locally. With the humongous disparities that exist in all of the U.S. Main urban cities, with all the diseases that exist here in the U.S. and in Canada and the developed countries, how do you envision your group or your institution to come up with some priorities to work in our very, very, very specific areas where we live?
Well, thank you for the question. I was at I was at the University of California, UC San Diego State yesterday, and listening to some of the incredible work that they're doing on dealing with the domestic challenges that face this country. So what we're doing, we've done a number of things. One is that we've had a session at our conference on local global. Next year, we hopefully have an all-day session on local global issues. And what we want to do is to be able to illustrate the challenges that are taking place in this country and also showcase the fact that these are challenges globally and look at innovations that we can take internationally and apply them to the challenges that we have here. The whole local global challenge is an opportunity, and it's a political opportunity. I was on the Hill about a week and a half ago advocating for research funding for NIH. And I think we all know what's been happening to NIH funding for a while. So 298 of us descended on Freudian slip, on Capitol Hill. You can delete that one from the thing. Thanks, Owen. That goes on the edit floor, right? Actually, the question was, of course, the local global challenges and how are we going to do a better job of addressing those challenges. So the situation on Capitol Hill, we know all politics is local. So how do we, if you have a Congress that's not terribly informed about international issues, don't care a lot about what's happening in global health outside of the borders, how do you capture their attention? I believe how we can capture their attention is to do exactly what you said, connect the local to the global. So what we are going to do is we're running sessions on local global at our conference. I hope we'll be able to have a session on an all-day conference on this in Washington. We're partnering with the AAHC. We've been in negotiations with them to have an all-day session on local global because the head of it, Dr. Steve Wortman, is very interested in this question. We sat down, he said, I'm really interested in how healthcare institutions can do a better job of actually dealing with the challenges that are faced within their own communities. How can we do a better job of that? And he also understands that those challenges, of course, are not only specific to the US, but they're global challenges. So we're in negotiations right now to have a session next year with them in Washington, which we hope to tape, to be able to bring together leaders involved in global health to showcase innovations in global health, particularly dealing in global health, public health, that address the social determinants of health, so we can actually showcase what are the challenges and, most importantly, what can be done. What are some of the leading lights in being able to deal with communities that are ignored, the homeless population, child health, immigrant health? How can we deal with some of the great challenges that exist here, and what are some of the innovations that have developed? So that one-day session, I hope, will be a platform for us to be able to share that, and we can tape it and also have it go international, obviously globally. Our site, we hope to be able to also showcase innovations that can be useful to deal with local healthcare challenges that the country faces. So it's a matter of extracting that information, putting it up, and being able to share it widely. What I hope we can also do is actually take the information in the IHME report. Did everybody see that, the state of U.S. health? Did everybody see that? If you haven't seen it, take a look at it. The Institute for Health Metrics and Evaluation did a very, very interesting look at the state of health in the United States. But they bored it down right down to a county level. So for any policymaker in this country, this is gold, and it should be used. So it identifies the problems, it identifies where those problems are. What we can do, with your help, is identify what some of the solutions are. How do you treat indigenous individuals who are drug addicted on the street? What are some of the smart ways of actually dealing with homelessness to provide secure housing for people? What are some of the challenges to dealing with malnutrition? How do you deal with food security in the United States? In the Bronx, check out the malnutrition levels in the Bronx. would scare you. And in the shadow of Capitol Hill in Washington, there are HIV rates that approach 3%.
We have a center here in LA.
Yes,
Nutrition, homeless.
exactly.
poverty levels.
Exactly. They're not,
Same thing.
that's right. But we have an opportunity to be able to take those bright lights, whether you're looking at East Vancouver and what they did in terms of the North American Opiate Management Initiative to deal with those who have narcotic challenges, to interesting housing solutions that have been done to convert public housing into unused public housing into long-term housing for those who are homeless. There's a lot of really amazing work that's being done. Now our challenge is to be able to share it and also to be able to promote it and advocate for it in an evidence-based and an intelligent and also interesting manner. If we do it in a dry fashion, of course, no one will pay attention. So we've got to add a little bit of zing to our message, right? Thanks so much, everybody, for your time. I really appreciate it.